Some people will say that Europe is in pain on several levels. Today we're going to talk about a very real type of pain, namely pain in muscles and joints and in the back. 1 in 5 Europeans suffer from chronic pain, and these people live with their pain for an average of 7 years. And despite treatment, 2/3 of them are still in pain. The total healthcare cost for pain in Europe now exceeds 300 billion euros, and the total cost for back pain now exceeds the total cost for cancer, diabetes, and lung disease combined. 1/3 of Europeans with pain claim that they've been poorly informed about the options to better manage their pain, and 4 out of 10 struggle to take care of their children, and 5% cannot manage to take care of their children at all because of their pain. Now here's a slide showing you the top 10 health conditions that cause disability in Europe. And musculoskeletal disorders is number 1, both in Eastern, Western, and Central Europe. Now this is a very, very long list of over 300 health conditions, and musculoskeletal conditions is number 1, just as it is in all other parts of the world, except for one place, and that's Africa, south of Sahara. So musculoskeletal disorders and back pain is truly a global problem and the number 1 cause of disability in Europe. If we look closer at musculoskeletal disorders and how much of the total disability it actually causes, this slide shows you the number of disability years caused by musculoskeletal disorders in different parts of Europe. And you can see that by far the biggest contributor to disability is back pain, then followed by neck pain, and then by osteoarthritis and other musculoskeletal conditions. So if we are really going to reduce the burden of disability because of musculoskeletal disorders, back pain and neck pain are natural targets. And in fact, they cause just around 20% of all disability in Europe. But this is really just the tip of the iceberg we're talking about. If we look at diagnosed arthritis conditions, diagnosed conditions in the musculoskeletal system, it concerns a very small part of the population, less than 1.5%. In fact, most of the patients in pain never receive a proper diagnosis for their pain. Around 20 to 30% seek care from primary care, from family physicians, physiotherapists, chiropractors, and osteopaths every year all over Europe. But over 50% of the population go to work in pain. And if you go to workplaces and ask people about their bodily pains, over 50% will say that they work every day with pain. They try to get help from primary care. Most of them still continue to live with pain. So not everyone in pain are a patient all the time, but most people with pain seek care from time to time in the healthcare system. And pain in many, as you will see in a minute, is often long-lasting, and it tends to recur. Muscle and joint pain is the most common work-related problem in Europe. It's the most common single cause of sick leave. And even though muscle and joint pain is more prevalent in the new member states in Eastern and Central Europe, it causes more disability in the old member states, such as in Belgium, where we are now. Recently, we've begun to focus more, not only on absence from work, which is a huge problem in the European workforce, but also a phenomenon that we call presenteeism. And presenteeism is about being at work, but being unwell and not able to work to the fullest of your ability. And it's estimated that presenteeism, the production loss caused by people going to work but not able to work to the full extent, is about 3 to 4 times larger than absence from work. That's why The Lancet, a leading medical journal, asked me and other international researchers to write a focused series of papers about back pain and what we could do about it all over the world for this global problem, including in Europe. And as you will understand when I'm finished with my talk, the main message from the Lancet papers was that we need to stop a number of harmful practices that we do to the patients with back pain and musculoskeletal pain in our healthcare systems, and ensure that patients have access to effective and affordable healthcare all over the world, including in Europe. And this is just to show you the different people from all over the world who were involved in writing this series. It was not just an expression of my opinion. It was truly a global initiative that involved academics with many different professional backgrounds. And I was fortunate to co-lead this initiative with Professor Rachel Buchbinder from Melbourne in Australia. When the papers were released, they caused major headlines all over the world. Printed media, electronic media, internet media, a lot of attention in many, many countries. Even the prestigious and important British newspaper, The Times, wrote an editorial about back pain, and I think that's the first time that has happened. And the message from the Times was that the National Health Service in the UK is wasting money on ineffective treatments and surgeries for back pain. And if we look at social media, almost 15 million Twitter accounts have received posts with the hashtag low back pain that we created for the Lancet Low Back Pain series. And already now, after less than 1 year, these papers are ranked as in the top 5% of the most influential research outputs ever ranked by international ranking agencies because of this enormous public health and media attention. Here you see a figure that shows you the prevalence, the occurrence of back pain. And the reason why I show it to you is because you can see that back pain actually starts very early in life, and it continues until we become very old. The red columns here represent women, and the blue columns represent men. So women have more back pain than men do, but it starts early in life, and that's a fairly new and important realization. The next figure shows you disability of back pain throughout the lifespan. And you can see that already at quite a young age, back pain starts to cause disability in people. More importantly though, this figure shows you how disability caused by back pain has increased from 1990 to 2015. The red columns here indicate 1990, and the blue columns indicate 2015. So you can see a steep increase and a significant increase throughout the lifespan. In fact, the total increase in disability caused by back pain is more than 50% in only 25 years. And you can see also that the biggest increase and the biggest impact is in midlife, when we are supposed to live our life to the fullest, to be most productive, and from a societal perspective, go to work and pay our taxes. That's why this is a societal challenge as well as a healthcare and medical challenge. This figure is just to show you that the pattern is exactly the same all over the world. These lines represent different global regions. You can see across the lifespan that back pain peaks in midlife, but you can also see in the green line here that Europe is on top. Europe has, of all global regions, the highest prevalence and the highest burden of disability. So we can talk about the massive societal impact in terms of occupational groups, in terms of disability, in terms of money, and more recently, we have become interested in knowing about the impact of living with back pain for individuals, for citizens. What does it mean for a person to live with persistent back pain in their lives? And here are some results of 38 recent studies where we have interviewed people who live with persistent pain. And it's really quite a depressing read on top of all the depressing numbers. They talk about the undermining influence of pain, worry and fear about the social consequences of living with pain, hopelessness, family strain, social withdrawal, loss of your role in life and of authority in your family and in your community. They talk about unsatisfying relationships with healthcare, and they talk about resigning, learning to live with pain, and coming to terms with changed life conditions. And I think these studies and these messages really help us better understand what's behind the numbers. What does it mean for people to live with pain? What then is back pain? Is a topic that we wrote extensively about in The Lancet, of course. Of course, it's about pain. It's about nociception, pain impulses coming from the back and hurting people. But increasingly we come to understand that back pain is not only about the back. It's also about the central nervous system and how pain is being processed and perceived in the brain. In people with persistent pain, we actually see not only physiological but also anatomical changes in the brain. So if you've had pain for a long time, it's not enough just to treat the back. You need to treat the central nervous system as well. We now know that people with back pain many times also have other health conditions like asthma, diabetes, poor mental health, poor nutritional status, most commonly obesity, and they have pain in other parts of their body too. We know that social factors such as short education, low income, heavy physical work, and poor access to healthcare are very important in both the prevalence but also in back pain disability. This is, besides being a medical problem, it is also a social problem. And we know that mental health in the form of depression, anxiety, low self-efficacy, illness perception, yet you cannot do anything yourself, hopelessness, contributes to pain and disability. And we've come to understand that there, for much of this syndrome really, is a strong underlying genetic disposition that we need to take into account when we tailor new treatments and work with people. This is a slide that illustrates the impact that our social and healthcare systems can have on work disability caused by, for example, back pain. It shows 6 countries, including several European countries, Denmark, Germany, the Netherlands, and Sweden. And out to your reading left, everyone's on sick leave. And the different lines then show the return to work rates. And the further down they are, the more people are back at work. And the steeper they fall, the quicker they get back to work. And you can see that in Holland, they're pretty good at this, getting people back to work. Whereas in Germany, it's very slow and actually not that many return to work once they have over almost 800 days, this is several years, when they have been sick listed with, for example, back pain. And that's of course not because Germans have weaker backs or worse backs than the Dutch. It's simply a reflection of the way we organize our social and healthcare systems. And it's a good example that shows that it matters. It's not only a healthcare problem, it's also a social and societal problem. We've also begun to follow patients who seek care in primary care and ask them very frequently about their pain. And what we can see is that the outcome of the care that's delivered in primary care is really not that great. Because after 1 year, 60 to 70% will say that they are still in pain or they would have had a recurrence of their pain. And we know that the people who report persistent and recurrent pain are more often people who are passive copers, who feel they don't have control over their health and their lives. They have low expectations of recovery, don't think they'll ever get well. They have negative beliefs, and they have a low level of education. So back pain is very common. It causes more disability than ever. It affects individuals and their lives profoundly. It costs a lot of money. And our healthcare system is not doing a good job in helping people. And our social systems show a wide variation, and we can learn a lot of each other in the European countries by exchanging experiences with this. And really, we are only seeing the tip of the iceberg in the official statistics. So this concludes the first part of my talk, talking about the burden and the need for more attention to back pain. And I go on. Because, this is also hopeless and depressing. But I think there is a way forward. And we think so on behalf of the Lancet author group, that there is a way forward. But it needs to be a focus and concerted effort. I'm going to talk very briefly about scans and testing, about prevention of pain, about injection and surgery, pain medication, patient education, manual treatment, exercise, and about seeing back pain in a public health perspective. Now, more often than not these days, if you have back pain, you go to your doctor and say, I want an MRI scan of my back. Now, we are seeing rates of imaging rise in most countries, in Europe, in the United States, in Australia, and also in low and middle income countries. But what this slide is showing you is some of the things we look for on those scans, like do you have a disc prolapse, do you have degenerative changes, wear and tear in your spine. And it shows you that with increasing age, these findings also increase. And by old age, they're almost 100% for most of these findings. So it means that these findings are very, very common, also in people who don't have any pain. So they don't tell us very much about what's wrong with the back. So when we look in the scientific literature and ask the questions whether MRI findings can identify patients with back pain or sciatica that respond better to particular treatments, so can the scan help us to match the patient to a particular treatment that will help them? The answer is no, they cannot. Well, does it then help us to predict the future of the patient? Can it help us inform the prognosis so we can help inform the patient of their prognosis? And the answer is they cannot. And that is why there's actually no evidence that MRI scans improve patient outcomes. And that's why guidelines consistently, evidence-based guidelines, I'm sure even here in Belgium, recommend against the routine use of imaging for people with low back pain. Yet we see imaging rates increasing. The rate of complex imaging for patients have increased by 50% between 1995 and 2015. And many of these images have been wasted healthcare resources that could have been used much better in other ways. If we look at prevention of back pain, many of the things we've been doing, we now know are ineffective. These are things like ergonomic interventions in the workplace, back belts, insoles in shoes. They have been it's been convincingly shown that they have not helped prevent back pain. What we do know, though, is that targeted patient education and exercise actually does help prevent new episodes of back pain. This is a study that was published in the Journal of the American Medical Association a couple of years ago. And it is a synthesis of all the research in the area. And it shows that with patient education and exercise, we can expect a 45% reduction in recurrence of back pain with patient education and exercise. Now, this is a very large effect size. If we had a pill that could do that, we would give it to every back pain patient that came through the door. This is more messy, it costs a little more, but nonetheless, we know it works. So patient education and advice to remain active and go back to work are generally and universally recommended as first-line treatments for all people with back pain, and even for people who don't seek treatment. If we look at non-pharmacological therapies, again, exercise is highly recommended, generally recommended, but also interventions like spinal manipulation, massage, acupuncture are recommended by guidelines from all over the world. If we look at pharmacological therapy, this is probably where the biggest paradigm shift have taken place, because 20 years ago, we used to recommend pharmacological therapy as the first-line therapy for back pain, but not anymore. In fact, there's now emerging evidence that much of the medication we've been prescribing to people with back pain does not help them very much, and in fact does a lot of harm and causes many side effects. This is why, for example, the American College of Physicians, which is the largest scientific society for family physicians in the world, now for back pain in their new guidelines recommend that for acute pain, clinicians should initially select non-pharmacological treatments instead of pharmacological treatment. And also for chronic back pain, clinicians should select non-pharmacological treatments and use exercise, rehabilitation, spinal manipulation, cognitive behavioral therapy instead of pharmacological treatment. For invasive treatments, we now know that surgery and injections have a very limited place for most people with back pain, only if you have very specific indications and conditions, and when you know the surgical target, should you go in and operate. That can be for disc herniations that are of a certain type, or, for example, if you have extensive degeneration of the spine and spinal stenosis. But the more radical types of surgery, where you also go in and make the spine stiff and fuse the joints in the spine, probably helps very few people. And unfortunately, we are seeing these forms of more radical surgeries increase all over the world, including in Europe, in spite of evidence that they may not be helping, or at least lack of evidence for effectiveness. So we have a gap between evidence and practice, and let me just mention some of them. Guidelines consistently say that back pain should be managed in primary care, but we are seeing increasingly it's been managed in emergency rooms and patients are being referred to medical specialists. Guidelines recommend that patients should have education and advice, yet there are very few programs about systematic patient education. Guidelines say that patients should remain active and at work. Many clinicians still take people off work and even advocate for bed rest. Guidelines recommend that imaging should not be routinely used, yet we see imaging rates increase all over the world, including in Europe. And guidelines now consistently recommend that pharmacological therapy should not be the first-line therapy, yet it is probably the most common first-line therapy in most countries. Guidelines recommend against certain electrical modalities that's been used to put on the backs of patients. It's still being used worldwide. The use of strong pain medication like opioids is discouraged in every guideline that I'm aware of, at least for more than just a few days. Yet we see very high prescription rates of opioids all over the world, in particular in Europe and North America. Surgeries have a very limited role. We see increasing rates of surgery. So many examples of the evidence practice gap. We also see misconceptions in the general population. Here's a study where researchers asked people with back pain about imaging, and over half agreed or strongly agreed that they needed an MRI scan or an X-ray to figure out what was wrong with their backs. But I've just told you that most of these scans are useless and they tell us nothing about what's wrong with the patient's back. So there's something about beliefs in the population that we need to address from a healthcare perspective. But even worse maybe, general practitioners also have these beliefs about back pain that are not in line with guideline recommendations. And the non-evidence-based beliefs seem to be stronger among family physicians who have a particular interest in back pain. So many of them, for example, think that patients with acute back pain should be prescribed complete bed rest until the pain goes away, instead of remaining active and at work. Almost a quarter of them think that patients should not return to work until they're almost pain-free, when guidelines and evidence suggest that it can be helpful to return to work before the pain has disappeared. And very many think that imaging is really useful, even though there's very little, if any, evidence from studies about this. So we have a big evidence practice gap. We have a large burden of disease, yet this is not a prioritized research area in Europe or anywhere in the world. In fact, in spite of this burden, I have not seen a single call from the European Union in their framework programs or the Horizon 2020 programs or other programs that specifically targets the burden of musculoskeletal disease and back pain. And I just don't understand it with a problem of this magnitude. And there's a lack of funding and a lack of will to implement what we actually know works. And clinicians are often paid to do the wrong thing. They are paid to prescribe medication, they are paid to refer for imaging, but they are not paid to talk to their patients. Low-tech, non-invasive treatments have high out-of-pocket expenses for patients, whereas invasive and pharmacological treatments are often guaranteed and free. So the way we have constructed our system makes patients more likely to choose treatments and therapies that are not beneficial for them. And finally, I'm not aware of any evidence-based, focused national prevention programs in the area of back pain and musculoskeletal disorders in Europe. It's about time that we start to address these problems, from research to implementation of evidence and prevention programs. So in my opinion, there's a need for strong and coordinated action to address the global and indeed the European epidemic of poor care for low back pain. And we can do it. If there's a will, there's a way. Thank you very much for your attention.
Thank you very much, Professor Harvidsson.